So good morning, good afternoon, and good evening once again. Welcome to the session on the patient involvement in addressing AMR and sepsis risks. We have heard since this morning because today marks the second World Patient Safety Day, and we have this very rich program unveiling and unfolding all the different phases and all the different dimensions of the patient safety. And this is one of those sessions. And I will be probably not fair to other sessions to say that this is one of my most favorite, as it addresses the pandemic, the second pandemic, the lurking pandemic, and the pandemic that has been following us from before COVID, during COVID, and it is likely to stay with us for much, much longer. And in this sense, I think that the expertise that we have in the room shows the importance of walking the talk, something that we heard this morning. We heard that we had a great political commitment from MP Jeremy Hunt, then Dr. Abdullela with the JEDI Ministerial Declaration. Then we heard of the support from the innovative thinkers through different challenges and funds. But now we have come to a session where we will be discussing on how to make these practicable changes and how to really walk the talk, as our Dr. Tedros says in the WHO. In this session, I have a privilege, as I said, to invite three distinguished speakers who will be telling us the different aspects of the collaborations that are ongoing in this AMR fight. Thank you very much, the three of you, for joining us. I would first invite, so I will introduce the speakers one by one, so to give them the honor. So I first introduce Professor Dr. Konrad.
Neda, I think we have a problem. Could you go to the next speaker, and then we'll talk with Konrad back. We'll bring him back on.
Okay, would that work, Dr. Konrad? Is that okay? Okay. So then I have the privilege of inviting on the podium Dr. Bruce Altewat, who is Vice President and Head of the External Medical Engagement within the Pfizer's Hospital Business Unit. And apart from this title, what I can say and what is not written in your programs or the description is that Dr. Bruce is a real and very dedicated ally to patients, and a dedicated one in the sense of AMR trying to join our hands, trying to help patients get a better care, get the safer medicines, and preserve the ones that we have for the future. And as I like saying, he works together with us so that we really stick to the vow that we actually borrowed the antibiotics from the future generations and we did not inherit them from the past. So please, Bruce, the floor is yours.
Neda, thank you so much for such a kind introduction. And it's a true honor to be able to join each of you this morning, especially on such an important day of the World Patient Safety Day. And I'd like to just spend the next 5 or 10 minutes providing you an overview of how we at Pfizer approach antimicrobial resistance and what we believe is a business model that requires a different type of business. As Neda said, it's critical that we recognize we are borrowing these medicines from our future generations. And as such, we need to be good stewards of those medicines. So I'd like to share with you how we approach that. And then also talk to you a few minutes about the work we're doing with patient organizations, which honestly is the most fulfilling part of my job, to be able to interact with Neda, her colleagues, and other patients and patient groups. It is what drives me and drives our work each and every day. So thank you for this opportunity. Just a brief history of who Pfizer is and our involvement in this space. We've actually been an infectious disease company since 1840s. Our first product was Santonin, which was an anti-deworming or a deworming drug. During World War II, we were the largest producer of penicillin, producing over 6 billion units a month for the Allied soldiers. And today we have one of the largest and most diverse portfolios with over 80 anti-infectives. In 2019, our portfolio treated over 40 million patients. So this truly is a portfolio and a patient-centered component to our work. And we continue to evolve and support our commitments to leverage our products, but also the reach and the resources that a company like Pfizer has to address anti-infectives. In actually just about 5 years ago, in January of 2016, a group of companies came together to sign on to a series of commitments called the Davos Declaration and AMR Roadmap. And this really changed the trajectory of how industry approaches antimicrobial resistance. Pfizer was very proud to be one of the primary signatories and authors of this document. And in it, we committed to supporting measures to reduce the environmental impact of the production of antibiotics, committing to antibiotics only being used in the patients who need them, aligning our promotional activities with appropriate use. So for example, in the UK, we do not provide incentives to our sales force based on volume of sales. Partnering with stakeholders to improve access, not only to antibiotics, but we also recognize that we also need to ensure that patients have access to diagnostics and to vaccines, again, to drive that appropriate use. And then finally, advancing research and development through new collaborations and incentives. And I know you heard earlier today from Thomas Cooney and Dame Sally about a new initiative on the AMR Action Fund. It's through these that all these companies, so over 100 companies and trade organizations signed on to the Davos Declaration. And then we've established the AMR Industry Alliance to bring together pharmaceutical companies, biotechs, generics, diagnostics, to talk about how synergistically we can all come together to address antimicrobial resistance. Similarly, the Access to Medicine Foundation took it upon their charge to assess how companies were meeting their commitments. And it's an independent organization based out of the Netherlands that doesn't get any industry funding. And we were very proud that Pfizer, in the latest report, was recognized as one of the leading infectious disease organizations. In fact, we came in #1 around stewardship, which was to us most important, and the #2 overall company. But there is a way in which you can now assess independently how companies are meeting their commitments to the Davos Declaration. As we talk about antimicrobial stewardship, or AMS, our approach focuses on 4 key pillars. And we really, with the goal of really ensuring that Pfizer customers and stakeholders can develop achievable stewardship programs. So the first pillar focuses on education. How do we educate around optimal use of our portfolio, of the vaccine portfolio? You know, we do this through independent grants, which I'll discuss in a little bit, and direct engagement with providers. We generate new data to measure the impact of AMS, of stewardship programs, and their value proposition as a means to demonstrate to hospitals why it's so important for them to invest in developing stewardship programs. We lead the conversation on how to create a sustainable anti-infectives marketplace and address the economic challenges, bearing in mind that when you have a new antibiotic, you actually want to keep it in your cabinet. You don't want to use it. A new antibiotic is the last thing you want to use, because as soon as you start using a new antibiotic, you develop resistance. So we need to think about new commercial models to address the economic challenges where you don't want to drive volume of sales, but really ensure it's only being used in the patient that needs it. Provide a differentiated range of end-to-end solutions, and then strengthening the capacity to create more sustainable stewardship programs. And we have different programs focused on all of these pillars. One example around the awareness is the sponsorship we did a few years back from 2017 to 2019 of an exhibit at the London Science Museum that was focused on antimicrobial resistance. We were proud to co-sponsor this exhibit with other stakeholders and other companies, raising awareness around the important issue of antimicrobial resistance. Over close to 1.5 million people visited this exhibit over the time. And it's also now actually a roadshow. So the London Science Museum is leasing this out to other museums around the world so that we can, again, continue to strengthen awareness around this important issue. Pfizer also is very proud of our surveillance program, and we run a program called Atlas. And surveillance is very important because you need to be able to track resistance. Resistance is a global issue, but it's also a local issue. So the resistance that we may see in the United States could be very different from what Netta sees in her country, or where we see in India or Italy. And we need to ensure that our public health officials, our policymakers, and our providers understand where and how those resistance patterns change so that they can prescribe the right antibiotic to address the resistance patterns within their country. Pfizer has a program that's been operating for over 15 years in over 70 countries. And we actually are committed to transparency and access to this data. So we have all of our data available on a website for providers, for public health officials to have access to. You also can have access to it over a mobile app. And we're very proud of this free access to it. And we continue to believe that this is a very important obligation and ethical responsibility for a company. If we have this data, we have to collect this data to provide it to the public. So again, how are we working with the patient community? And this is, again, one of the most important pieces of my work, and one of the components I'm most proud of. As we think about the patient community, the kind of shared vision that we have is we really want to have an informed and engaged patient community who can understand the urgent health threat posed by antimicrobial resistance. We want to work with the patient community. We want the patient community to work towards encouraging policies around the appropriate use of current anti-infectives. And then also, again, how do we incentivize the next generation of those anti-infectives given the position of the pipeline? Traditionally, as we at Pfizer and other organizations have thought about patient engagement in the anti-infective space, it's been a bit narrow, and we've looked at it just to think about infectious disease organizations. But I think importantly, through collaborations with Netta and others, we've really taken a step back and said, well, wait, actually, patients from every therapeutic any therapeutic area are impacted by drug-resistant infections. And therefore, we have a responsibility to work with all of these patient organizations to educate and strengthen the awareness. Oncology patients who have immune systems who are compromised through chemotherapy and need to have critical access to antibiotics. We will hear from Dr. Reinhardt soon about sepsis and how sepsis can impact any of these patient groups. So we've really tried to take a global approach to the organizations we're working with, and then a cross-therapeutic approach. Again, recognizing that just working in the yard and getting pricked by a thorn bush can give you a drug-resistant infection, and we may not have the medicines that you need to treat it. So in 2019, November of last year, we hosted our first AMR Patient Summit. And to my knowledge, this is the first time industry has brought together patient groups. The key topics that we discussed during this was the patient journey, understanding where and how patients move through the healthcare system, and how drug-resistant infections can impact the patient throughout their entire journey. Introduction to anti-infectives and AMR. I mentioned we're working with many organizations who haven't prioritized or don't understand how drug-resistant infections could impact them. So trying to work with that. Thinking about the global policy issues. And then importantly, we had a panel, we had patient stories. I had a panel to learn about best practices that some patient groups are using around AMR advocacy. And then most importantly, we had a workshop to understand the priorities of the patients. And we use those priorities to inform our work going forward and our strategies going forward. Some of that is listed on this slide. This is not comprehensive, and I'll be excited when we will be able to announce some future initiatives that we have as well. But we've established an AMR Patient Council. Netta is a member of this council that meets on a monthly basis right now. to continue to engage and inform Pfizer on where and how we should be working on issues that meet the needs and priorities of the patients, and understand and identify opportunities for partnership. We will be hosting our second annual Patient Summit and Advisory Board in November, to continue to engage, educate, and most importantly, learn from the patient community. Raising the voice of the aging population. We've partnered with an organization called the Global Coalition on Aging to organize a couple webinars and regional workshops in Europe and Japan on AMR and the threat that AMR, drug-resistant infections, have to the aging population. And then importantly, also around awareness, we've issued a series of independent grants to support the development of AMR awareness materials. Again, IAPA was a recipient of one of these grants. Really, again, trying to ensure that materials that are developed meet the needs and address the needs of the patient community and speak to the patient community. And as such, those materials shouldn't come from Pfizer. They really ought to be and need to be from the voice of the patient community. So with that, I think that was my last slide. I, again, thank you very much for the honor to be able to speak with you this morning, this afternoon. Look forward to future questions and potential. I hope to meet you in person next year. Thank you very much, Netta.
Thank you, Bruce, for this very informative presentation of what Pfizer is doing to involve the patients, and we are really thankful. I will just pick up on one of the points on your slide, and that is the commitment to really preserve. So it is not only for Pfizer to become the leader in developing or in expanding markets, but rather to preserve those medicines that we have at hand, and you are really doing that work with us. We'll just mention the AMR Patient Council that you mentioned in the last slide. It is really a great opportunity for us that you provided a fora for patient organizations from all kinds of therapeutic areas, where we can really see the cross-cutting nature of the AMR. So be it sepsis alliances or cancer patients, other patient safety groups, and IAPO as an overarching, we can see how multidimensional AMR becomes and how it affects everyone. But similarly, this goes same for sepsis, as these two, unfortunately, go hand in hand most of the time and many of the times. And then I would like to now call Professor Dr. Konrad Reinhardt, who will be first to congratulate him on the exceptional World Sepsis Congress Spotlight you had on the 9th of September. I really watched it carefully, and you brought different speakers with exceptional messages over there. So I would like to invite you now to share with us what are your perspectives and what are your messages on the patient involvement in prevention of the sepsis risks. Thank you so much.
I thank you for the opportunity to talk to you, and I hope I can share my screen in a second, and that you will see this presentation. I hope technically is everything okay now, and it's a great pleasure to speak to you, because indeed sepsis is most likely the #1 cause of preventable death and a major issue. And it was in 1896 that Sir William Osler, one of the most famous physicians of his time, said that there are 3 enemies for mankind, and by far the most terrible is fever compared to famine and war. And if you look at this presentation, publication which came out recently by the authors of the Global Burden of Disease report.
Professor Konrad, I'm sorry, we cannot see your slides. At least I can't. Can you please try to share? Because I think it is important that people can.
Yeah, of course.
I'm also not versed at this, but I think there is a green button called share screen. So. Yeah,
I did hit this button. So you see, do you see now my screen?
Not yet, maybe coming in. Okay.
Okay.
It's perfect now. Thank you.
Oh, wait a minute. Okay. So, sorry. Yeah, so I heard this quote, and you see this recent publication in the Lancet, from which you can learn that 11 million deaths, which means that sepsis is accountable for 20% of all deaths worldwide. And in some countries, and this is mostly in low-income countries, sepsis represents up to 65% of all annual deaths. And if you look at the numbers and compare them to the numbers of patients who die from hunger, this is still a major issue. We have made progress and have no longer that many deaths from war. We still have 9.6 million deaths from cancer, but COVID-19, which as we will discuss, is if you die from COVID-19, you will also die from sepsis, and most people with HIV also die from sepsis. And Dr. Tedros 2 years ago already called it a tragedy that most of the 6 million deaths which we considered to die at this time, among them 1 million babies, are preventable by vaccination, clean care, and early recognition. And in the spotlight that you mentioned only a few days ago, he made the point and reiterated that sepsis occurs in response to an infection. When sepsis is not recognized early and managed promptly, it can lead to septic shock, multiple organ failure, and death. And that this is also true for patients with COVID-19 who progress to severe disease, which means this is sepsis with multiple organ failure. So it completely fits the actual definition of sepsis, which is defined by an infection that leads to acute organ dysfunction, and it may derive both from bacterial, viral infections. So a major step forward in the fight against sepsis was that in 2017, the WHO, upon a coalition of states and nations under the leadership of the German Ministry of Health, adopted this resolution, improving the prevention, diagnosis, and clinical management of sepsis. And perhaps the most important urge in there to all member states is and was and still is to include prevention, diagnosis, and treatment of sepsis in national health systems, strengthening in the community and in health settings. And this indeed works. You may have heard from the fact that in 2014, Governor Cuomo from the state of New York put out and set out a regulation that asks and mandated all 200 hospitals in the state of New York to document what they are doing in terms of diagnosing and managing sepsis, including drawing blood cultures, providing antimicrobials within the first hours. And as you see, this is from their recent report. Since this time, on an annual and quarterly basis, there was a constant decrease of sepsis over time. And their goal is to reduce sepsis by 50%. So you may download this report. This is very encouraging. And the same happened also with support of the UK Sepsis Trust by the NHS, who declared sepsis a priority. And along with this campaigns and activities that resulted from this decision to prioritize sepsis, there was an increase of the number of patients who received and were screened for sepsis and received the antimicrobials within 1 hour, increased from around 30% up to 80%. And on this dotted line, you see that this went also along in UK with a significant decrease in mortality. Likewise, the same happened when the Irish Ministry of Health decided upon the unnecessary death of a pregnant women to educate every hospital and also the public in early recognition and appropriate management of sepsis. They were able to decrease sepsis mortality rate from the range around 30 to below 20%. So it is possible, and that's why it's true what Dr. Dettos said, sepsis is the #1 cause of preventable deaths. The good news is that in the meanwhile, there are a number of countries who have nationwide activities. And on last year's World Sepsis Day, despite the fact that Australia has already a pretty low sepsis mortality, the Minister of Health there not only tweeted, but also publicly announced that it is unacceptable that the majority of Australians have not heard the word sepsis and know what sepsis is as the common final pathway to death from most infections. Likewise, in France were such announcement and in Sweden, but compared to the 100 nations that we have worldwide, you see that we are just at the beginning. And what you can also depict from this slide, so it's of course the sepsis mortality rates and incidence depends on the resources for reason of availability of clean water, sanitation, vaccination rates, etc., etc. But also among high-income countries like Australia, UK, US, and Germany, you see that there's a big difference in the relative reduction of sepsis mortality rates over the last decade. And in Germany, we are not doing very well, despite the fact that we are the #1 country in respect to hospital and ICU beds. We have more ICU beds than the UK. So everybody, every healthcare worker, but also every citizen should know which signs are indicative that infection progresses to a life-threatening sepsis. And this is what it's all about, to educate lay people, but also the public. And if we want to bring the fight against sepsis on the next levels, we need to work together with WHO on the country level, with top policymakers, to ensure the enactment of the request of the WHO sepsis resolution. We address, and the policymakers need to understand that sepsis requires the same vigor and passion as the fight against COVID-19, which is just one single cause of sepsis. And in comparison to the numbers, it's not surprising. The awareness that we all have now, which is good to fight COVID-19, must also happen for the awareness from sepsis, from other viral sepsis like seasonal flu, but also Ebola and dengue, yellow fever, etc., and also, of course, from bacterial sepsis. And we need to learn from countries and health system and facilities with low mortality rates. And what we also need to achieve, not only that top-level policymakers in every countries and authorities from healthcare authorities must work and bring these issues, infection prevention, AMR and sepsis, under national infection management plans. And sepsis must also become a high priority for WHO, which you know has already an assistant director general against AMR, but and they work in different departments on sepsis issues, but there's no specific funding within WHO so far. And also the United Nations and UNICEF, the great funding organizations, need to understand that still sepsis as a common final pathway of all infections is a major cause of death and a major issue in terms of patient safety. And when we are successful during the next years to get this message, we can literally save millions of lives and make a major contribution also to the achievement of the sustainable development goals. And we need to work hard to overcome the existing silos which happen among health authorities, which happen within WHO, between AMR, infection prevention, sepsis, etc. So we need to seek and to look for the close interlinkage with these issues. With this, I am at the end, and thank you for your kind attention.
Thank you, Dr. Conrad. Again, we can see a great message of collaborations being so necessary, and I wish really one day we can put a price tag in a sense of how much those silos cost us in sepsis. So how much those disintegrated approaches cost each one of those lives, apart from the life itself, which is the most valuable. So by that, I think we can maybe get more the ear of the policy makers and decision makers. And it is devastating actually to hear the numbers that you presented, like 6 million preventable deaths, of which 1 million babies. And I believe, I don't know the details, but I'm sure that most of them are in the low and middle income countries where the lack of access to hygiene and other preventive measures is critical to preventing those. And by that, I would like to, I have the distinct privilege and honor to invite the third speaker who can share more about how it is to work on the front lines, how it is actually to be the real hero where all those challenges of lack of sanitation, lack of awareness of the antibiotics and their value, lack of many, many other aspects of the healthcare actually prevents people from getting a higher quality and safer care. And at the same time, how it is to try and contribute to the world, to the global fight. So our next speaker is Danjuma Ada, the Executive Director of the Center for Initiative and Development, Taraba and Chango Care Trust. I apologize for maybe not saying the name of the organization correctly, but I want to say a few more words about you. Besides being a Nigerian prince, you are an exceptional public health expert who is a tireless advocate and tireless fighter on the front lines, I can say, not only for hepatitis, but also for the rational use of antibiotics. So if you can share with us your view on how patients can be involved in the fight against AMR. The floor is yours.
Thank you, Nida. And thank you also for the opportunity to speak on this panel. Thank you to IOPO and thank you viewers for joining the Global Patient Congress. 4 days ago, while preparing to go to work, my phone rang. I couldn't pick the first time. The second time I picked the phone, and on the other line was this voice. Doctor, doctor. I was like, who is this? And he said, is Samuel your patient? Don't you recognize me? I said, oh, which Samuel is that? He said, the patient you met 3 months ago, you asked to run hepatitis viral loads, and I need to see you. I said, okay, no problem, Samuel. We could meet in the office at 4 p.m. Now, this is one scenario we experience in most of our communities in Nigeria and Africa. Community people look at anybody that works in a hospital as a doctor, be it a nurse, a pharmacist, or a lab scientist, they call them doctors. And some of these pseudo doctors practice what they're not clinically trained to do. They write even prescriptions, including antimicrobials and antibiotics to people in the community. And these people even consult without even clinical practice. Now, at 4 p.m., I was in the office, but 3:30, Samuel was at the office to see me. He was ushered in, and he came in and crashed into the seat beside me. And he was like, "Doctor, I have a problem." I said, "Samuel, what is it?" Now, before then, Samuel is a patient we met 2 years ago on one of our community awareness campaign and screening for hepatitis. He was tested positive to hepatitis B and C, and then, of course, to HIV. And he came to me this very particular day with so many forms and papers in his hands. And he was like, "Doctor, I have a problem." I said, "What is it?" He said, "Do you remember you asked me to come and do hepatitis viral loads and I couldn't afford it?" He said, "Yes." Now, Samuel, he works in a private firm. He receives 30,000 naira, which is equivalent to just $60 in a month. And he could not afford, of course, to come around these diagnostics. But he had this sexually transmitted infection that he has been treating for over 2 years before we even met. Samuel has been on self-medication. Why? Because he could afford to get antibiotics over the counter at a community store. He could afford to get all sorts of drugs by unregistered patent stores. That is also the scenario we find in most of our communities. Apart from Samuel, I have this kid sister called Pharaoh. She has a poultry farm. 2 weeks ago, she bought 500 birds. And she called the veterinarian to come. And when this veterinarian came, he came with a bag full of drugs, including antibiotics. And he was like, "Pharaoh, we need to give your birds these antibiotics to boost their growth so that you can sell them on good time." And of course, he administered all those drugs, including antibiotics, to these birds. And that is also almost the same challenge we experience in some communities in Nigeria and across Africa, where you have in the open market antibiotics and all sorts of drugs that are sold by lay people, untrained people, unskilled people, selling to the communities. And most of these business people will buy these drugs in their own way to boost their market, to boost their farm produce and also their animals so as to increase their income. Now back to Samuel as the patient. Samuel had this disease. He went to the hospital when he had challenge with this sexually transmitted infection, gonorrhea and syphilis. And because this thing has eaten so much into him, he now met this doctor who asked him to run urethral swab and urine culture and sensitivity. The result came out. Unfortunately for Samuel, only one antibiotic was positive sensitive, all the remaining were resistant. And the doctor now wrote this particular very expensive drug for Samuel to buy. And Samuel could not even afford to run the hepatitis viral load we asked him to do, not to talk of even buying these antibiotics. This also is a very clear example of many patients we have, the community members we have in most of our communities in Nigeria and even across Africa, where they do self-medication because out-of-pocket expense is the highest way of financing health in our communities. Now, this is my slide, and I'm sharing the patient perspective, the community perspective, the stories of people like Samuel and people like my kid sister Pharaoh, who in the agricultural sector, who also abuse the antibiotics and fuels and drive the antimicrobial resistance challenge in Nigeria, even across Africa. Now, the challenge we have is that in most of Africa, in Nigeria, for example, Nigeria has a very large population of over 200 million people, and we have a very high disease burden and also a very high population. Unfortunately, my slide is not moving anyway. So we have a poverty index of about 40% of people that even lack, in fact, about 90% of our people lack access to health insurance, and about 27% are living under the poverty line. This high burden of disease of over 19 million people, for example, in Nigeria, living with chronic hepatitis. A majority of these patients lack access to quality healthcare. Their out-of-pocket expenses like 90%. And the catastrophic cost of healthcare is driving some of these people into poverty, and they cannot afford the minimal cost of diagnostics. The example is Samuel, the patient I just talked about. He earns about $60 a month, yet there's a requirement for him to run the diagnosis that will cost him over what he earns as his salary. And because we have unregistered and poor regulations, most of these patients access these drugs and antimicrobials for most of these unregistered patent stores. Nigeria consumes over 60% of pharmaceutical products in West Africa. But unfortunately, we also have issues around poor regulations of antimicrobials and poor regulations of drugs, which goes a long way to affect antimicrobial resistance challenge across the nation. And it's a big problem that fuels resistance. Now, this is a slide about Nigeria. Well, what are the factors that mitigate successful AMR response in Nigeria? Poor public awareness and patient empowerment. A patient like Samuel, there's very poor knowledge of antimicrobial resistance. There's also poor access to healthcare. There's inadequate information, financial barriers, because over 90% of the population spend out of pocket. There's high disease burden. There's low healthcare worker ratio to the population. A doctor to 3,500 people in the population is so high. There's also poor funding for AMR activities, whereas there's high demand for antimicrobials by patients. In some communities, we have this culture where patients demand for antibiotics and they feel without antibiotics, their disease cannot be treated. And healthcare workers are pressured to provide these antibiotics and to provide these drugs because of the pressure from patients. And of course, in the agricultural sector as well, there is abuse because people want drugs that will boost their production. Like the example I just gave of a kid sister who the veterinarian gave the antibiotics to boost the growth of her birds. At a community level, there's poor hygiene and infection prevention at both community and hospitals. And unfortunately, there's lack of antimicrobial stewardship in both private and public sectors. Now, what does CFID do? CFID, as a patient-focused and patient-driven organization, patient safety is one of the focus and what drives what we do. We received this grant from Pfizer and we implemented 2 interventions. One is on hepatitis B vaccination as an antimicrobial stewardship strategy, and 2, on healthcare workers educational program and community awareness to set up antimicrobial stewardship programs in Northeast Nigeria. Before conducting these activities, we carried out baseline and the result was alarming. Over 63% of healthcare workers had no up-to-date information on AMR. About 88% of them had no on-the-job training on AMR. And over 65% of healthcare workers have not received hepatitis B vaccines, despite the risks that they expose themselves and the work they do in the hospitals. Over 76% of people living with HIV that we screen have not received hepatitis B
Just a reminder, we have 1 minute. Thank you.
So all the hospitals have no AMS programs. So what did we do? Our intervention is built on the theory that every infection prevented is one that needs no treatment. And that's why we provided HPV vaccination and training for healthcare workers to strengthen healthcare systems on setting up of antimicrobial stewardship programs and to do community awareness to increase infection prevention. A patient like Samuel, if he had information about where he could access healthcare service, or if he had support, a patient like Samuel would have, of course, avoided self-medication. Now, what do we need to do? There's need for increased financing on research and development and increased support for national surveillance on AMR across not just Nigeria, but across Africa, and increased community awareness and patient empowerment. Unfortunately, patient empowerment is a key focus in most AMS interventions and even AMR activities in Nigeria, even across Africa. And there's need for continuous medical education for healthcare providers and to strengthen infection prevention and control at the community level. Wash and hygiene practices are very low in most of our communities. These are pictures of what we've done at the community level, where we provide vaccinations to people living with HIV. We train healthcare workers on antimicrobial stewardship, and unfortunately, because of the COVID-19, to start up AMS active interventions across 14 hospitals. Thank you.
Dan, thank you very much. Neda, do you want to wrap up quickly?
Well, I can wrap up by saying that this session is really bite-sized at this moment, and we would like to see it unfolded. And I would like to invite the 3 speakers and few other speakers we would have in the next series of webinars we are developing after the Congress on different topics, and AMR will be one of them. The key message for me from this session was that we need to work in partnership, and we need to really address globally the issue of AMR, because it is not only a problem or a public health threat in the developing countries, but it is also in the developed, and likewise for the sepsis. So if we want to see it eradicated, we have to look into every corner of the globe. And thank you very much for your detailed presentations. I'm so sorry we don't have time for Q&A this time, but watch out for, this is to the attendees, watch out for our announcements for the webinar unfolding this topic in more details. Over to you, Kavaldeep.
Thank you very much, everybody. And Dan, Jim, I think we'll have a session now for Africa, African Congress we plan, and we'll include that in. And Conrad, thank you very much again for being present and all that care and support you have given us. And Bruce, thank you again for coming up so well with us. And now I'll ask the audience to go back into the auditorium and link into the next session, which is really brings what all these 3 speakers have been saying together, that we have to look at it as a holistic matter, and it is a joint patient health professional responsibility to address patient safety, and hospital-acquired infections and AMR and sepsis are the big issue. We must work together. So thank you, and see you on the other side. Thank you.